or someday in the future if you're watching our recording. Before giving the floor to our dearest guest, I would like to introduce our team. My name is Madonna Akhopadze. I'm a neurosurgeon from Georgia, Sakartvelo. I'm also a PhD candidate and assistant professor in Tbilisi, capital of Georgia. A couple of words about our online education meetings. They have started with Professor Hasan Kamil Suju, the program manager of the neurosurgery department of İzmir Atatürk Training and Research Hospital in Turkey. And these lectures go on with the contribution of all the neurosurgeons and residents of neurosurgical program who have graduated from the same department, and as well neurosurgeons and neurosurgery residents from nearby countries like mine, Georgia, Sakartvelo, Bulgaria, Ukraine, Kazakhstan, and many others. Now, a couple of words about protocol of today's meeting. In order to avoid any noise or voice pollution, all the microphones will be switched off during the presentation of the lecture, but you can ask your questions or share your comments by writing them in the chat part of the Zoom section. And at the end of the lecture, I'm going to ask them to the lecturer, and all of the questions will be discussed accordingly. However, mutual discussion is not appropriate for the format of our meeting. And now, without further ado, it's my biggest privilege to present today's lecturer, Professor. Let me share a couple of words about his from his biography. Levent Özçakar. He's a professor at Hacettepe University Medical School, Department of Physical and Rehabilitation Medicine, Ankara, Turkey. He has finished medical training in 1997 and residency in 2002 at the same institute, where he has been also entitled as associate professor in 2006, and later professor in 2012. His main areas of interest include musculoskeletal ultrasonography and scientific publishing. He has organized workshops and delivered lectures on these topics at the numerous national and international meetings. Professor Levent Özçakar has 818 publications in peer-reviewed journals, and number of Web of Science citation is 5,023, and Web of Science Age Index is 33. He's also a reviewer in 90 different international journals that are indexed by SCI and CS experts. So he is an associate editor at the European Journal of Physical and Rehabilitation Medicine, as well as book editor for musculoskeletal ultrasound in physical and rehabilitation medicine, sonographic atlas for common musculoskeletal pathologies, and ultrasound imaging and guidance for musculoskeletal interventions in PRM. He is a founder and president of Turkish Musculoskeletal Ultrasound Study Group, as well as European Musculoskeletal Ultrasound Study Group, also World Musculoskeletal Ultrasound Study Group, and Turkish Multidisciplinary Ultrasound Society, alongside with Ultrasound Task Force of ISPRM, and Special Interest Scientific Committee of Musculoskeletal Ultrasound Society. Thank you, Professor, for being our lecturer today, and you can start sharing your screen. Virtual stage is all yours. Thank you.
Okay, thank you very much. This is my great pleasure and honor to be giving this lecture tonight. And I would like to start by thanking the organizing committee for this nice series of lectures. I've seen several of them and followed several of them in the YouTube channel. I also suggest that you subscribe and follow them, and as well as for their kind invitation. So I've seen several people from different countries, so I would like to greet you all with one of our recent titles, From Magic to Strategic and Logic in Hemisphere Ultrasound. Focus, focus, and focus. I mean, focus stands more for the magic side. You will see in the coming slides why I call it magic, because it does have magic for us. Focus is point of care ultrasound, so it represents the common and easy, convenient use of ultrasound in our daily clinical practice. And focus, of course, stands for the focus function of the machine, as well as for the focusing of ultrasonographic findings in relevance with clinical findings. You will see in the coming slide, we're not radiologists, so what we are doing is ultrasound examination rather than ultrasound imaging. By far, more than what they've been doing is imaging alone. So this is The fake title is ultrasound and ultrasonography because it's something like electromyography. I mean, we use sound waves to do some sort of imaging for the nerves, but the real title is ultrasound imaging and guidance for nerve. Imaging and guidance, they are all together, hand in hand. You cannot separate one from the other. And it's also the title of our recent book, the red book, which is on interventions, the bloody book. And if you're interested, you can check for the beginner book, the blue book, and for pathologies for the black book. And again, if you would like to read different translations, Chinese version even included are on the market. So I'm Levent Özçakar. I'm more based in Hacettepe University Medical School, but I have all affiliations. And these are our social media groups. And if you're interested to join us, especially the Euromusculars or the Turkmus, you're most welcome. Today's content will mainly comprise some exemplary cases from our daily practice and some data, our data. And I don't think I will find time to touch upon technical details, but perhaps upon questioning, we can dive into those details if there are questions accordingly. Now, the first rule in MSK ultrasound is seeing is believing. Now, I just mentioned that we're clinicians, we're not radiologists. I mean, most of us are not surgeons either. Surgeons have the privilege to cut and see, but as clinicians, we don't have the chance to cut and see. But I will exemplify in some cases, sometimes we even see better than perhaps a surgeon can see because during surgery, a normal structure, a surgeon would never want to go inside a median nerve to open and see whether there is an aberrant structure. But with ultrasound, we can see even sometimes further than a surgeon. So seeing is believing. This is our concept. This is the first rule. And you can check the title of the journal, 1999. By the way, this is also the year that I have started doing ultrasound. So next year I will be celebrating my 25th year in MSK ultrasound. You can see the name of the journal is Veterinary Journal. So even in years where MSK physicians or neuro physicians were not interested in doing ultrasound, veterinary physicians were even checking animals and horses using MSK ultrasound. And this is a very nice editorial that we commonly use. Actually, this is the only paper that I'm going to cite other than our papers in the rest of my presentation. So the first rule, seeing is believing. Now, as I mentioned, in clinical practice, we are faced with real patients. So that's our patient. We just listen to the medical history and we just finish the physical examination. And only then, after these steps, we do MSK ultrasound examination. It's not something like what radiologists are doing. Okay, there's shoulder pain, let me check by ultrasound. This is not the concept that we are doing. So this is how we are left with the limb. But if you would like to see really what is actually going on inside, you just put the probe on the patient. And this is just an example of a median nerve just dynamically moving. That was actually my median nerve in the forearm of the patient. So seeing is believing. Now, the next question would be, okay, but which tissues can be seen with ultrasound? A short copy-paste answer would be anything that is not covered with a bony tissue or with a calcified tissue can be scanned, including the periosteum and the cortex. So all the soft tissues above can nicely be scanned. And in certain places, you can mobilize certain areas and perhaps even try to see what is below the bony tissue. But if we are talking about an intraosseous pathology, currently the ultrasound technology will not let us send sound waves, let them reflect back and convert them to pixels. This is not possible at the moment with current ultrasound technology. So anything outside the bone can be seen. Just a short answer. Now, the second rule is if you can see things, you can quantify, you can qualify, or you can semi-quantify. And I've just given two examples from two meta-analyses of ours on ulnar nerve entrapment syndromes. One is related with, one is related with the cross-sectional area measurements in cubital tunnel syndrome. So now we have cutoff values. And the other one is other parameters that you can check, not just the CSA values, but other parameters that you can check if you suspect of cubital tunnel syndrome in your patient. So like EMG data, like latency values, like amplitude cutoff values, we do now have strong evidence, robust data, how to sonographically diagnose these patients using these parameters. Another meta-analysis of ours would be a good example on diabetic patients. Now, these patients already have polyneuropathy. So if the patient comes to you in the clinic with carpal tunnel findings, how are you going to diagnose whether it's related with the local entrapment or with the underlying uh, polyneuropathy in advance? So for these cases, again, morphological assessment is quite contributory and very much paramount in clinical practice to distinguish in between. And at this point, I need to put a parenthesis and say that EMG and ultrasound are not competing, they are complementing each other. One is a functional evaluation, the other one is a morphological evaluation. So it's better to complement these. In my department, we have the two rooms just next to each other. So complementing both would be fine. But with EMG, you are usually almost always not able to tell, okay, there is an entrapment, but what is the underlying cause cannot be told with only EMG. So don't forget, these are complementing each other, and it's very much contributory if you use them concomitantly. Now, the third rule is if you can see something, you can have access to it. And that is the rationale behind the interventional ultrasound. So this little offensive title was written some years ago to imply the impact of ultrasound, not just for precise targeting. There was no discussion about it, that you can precisely target your tissues. But this was written because ultrasound is also important before the intervention for clinical decision making. Sometimes ultrasonography findings will tell you don't touch this patient, or perhaps immediately send the patient to surgery. So there are several advantages of ultrasound, which you will see in the coming slides as well. Why I use the word magic, and okay, general advantages like simple, cheap, convenient, no radiation, high resolution, and vascularity assessment is very much important, especially for MSK ultrasound. Close follow-up, very convenient. You can do it perhaps 3 times a day or 3 times a week even, but you cannot ask for MRI or CT that frequently. Dynamic imaging is very much important because we are talking about tendons, nerve, muscles. We're not talking about gallbladder ultrasonography. We're talking about neuromusculoskeletal ultrasound imaging. So dynamic imaging is very much important. Comparison is not just a superiority, but it's also a prerequisite. We never comment, we never uh, finalize our decision unless we compare with the asymptomatic side of the patient, or in cases with bilateral involvement with that of a normal person. And there are some extra parameters or extra features of ultrasound that you can use, like sonar palpation. In nerves, this is also referred as sonotinal. So, like you're doing tinal testing for the entrapment neuropathies, or if the patient is intellectual enough, you can even give the probe to the patient and just put it in the most symptomatic site. I just tried to mention about virtual dissection. I will give examples in some aberrant structures regarding entrapment syndromes, and of course, no discussion about guiding the interventions. Therapeutic, we use this as sonofeedback. I mean, we have biofeedback in rehab medicine, but we usually suggest that you share the screen, either the static images or the videos, either during diagnosis or the interventions with the patients, because this is quite user friendly, patient and physician alike. So just reassure the patient showing the pathology or showing the exact placement of the needle and draining the fluid inside any area that is symptomatic on the patient. This really provides stono feedback, and the patient is really very much happy to see what's going on inside as much as the physician. So I just mentioned about sonotinal. This is one of the recent papers we call as reflex hammer. So the probe of ultrasound is like a reflex hammer, but this time it's showing inside. So this was an example of how we could diagnose, locate and diagnose schwannoma. I will tell in the coming slides how we diagnose them, but just to exemplify how magic it would be to have a reflex hammer that simultaneously shows inside your patients. And these are the corresponding operative images sent by the neurosurgeons. Now, at this step, another parenthesis that I need to put here, sometimes people say, yeah, but we have CTs, we have MRIs, we have so sophisticated technologies. Why should we, stay confined to ultrasound imaging? No, the the fourth rule perhaps would be if ultrasound can show it, it is definitely better than MRI. So I usually use this example. If ultrasound is BMW X6, MRI, especially for peripheral nerve problems, is Honda Jazz. I mean, with MRI, you just thank God that you see the nerve. Otherwise, you don't have all the details that I'm going to simplify in the coming slides. So don't forget, ultrasound can show it definitely and definitely superior to MRI. It's not just because we do it, it's because it's high resolution and it's because of interactive and dynamic imaging capabilities. Now, I'm mentioning about examination. Yes, I use it on purpose. It is not something just imaging, it's ultrasound examination. But don't forget, it can only be the sous chef. I mean, the clinician or the surgeon is definitely a master chef. It can do many things with the expert hands, but you have to be the master chef and you have to guide the sous chef. Okay? Alone does not make sense, but if used appropriately, it's definitely the sous chef. Coming back to peripheral nerves, what can we see with the peripheral nerves? We can see the fascicles. Yes, we do. We can see the perineurium and epineurium. We can assess the vascularity. It's not just the MRI or the contrast imaging with the MRI. We can assess very much with high resolution the vascularity. And I just noted that the nubile soft tissues, mainly causing the entrapment syndromes, is assessment of these structures is very much important in clinical practice, which is usually not shown by, not possible to assess by EMG. So, in practice, it provides morphological confirmation. It provides or it tells us what the underlying etiology would be, or it is actually, especially with widespread involvement, not just with polyneuropathies, but also I will show examples of neurofibromatosis. It's not possible to scan whole limb by MRI or whole body by MRI, but just holding the probe and putting anywhere you would suspect, you can scan any nerve so you can easily understand the extent of involvement, especially widespread involvement diseases. No questions about interventions. I said it guides precisely, but sometimes refrains or modifies the technique. Sometimes it will tell you, don't put this injectate, but rather put this one. Or don't go from this side, but go from that side. Definitely helps the surgeon. I will again show examples how we can, in advance, navigate the surgery, or sometimes refrain from surgery, of course, and definitely provides close follow-up. So even if you do an intervention or surgery, it's very much convenient. You can ask the patient to come 3 hours later, 3 days later, 3 weeks later, or 3 months later. Very much convenient. How do we scan? I said I don't go into technical details, but we usually scan in the axial view because the nerves are not just straight ropes like this. They are sometimes diving deep, sometimes lateral, sometimes medial. So you have to scan axially, and then any place you suspect of a pathology, that's a rule. You have to also scan in the long axis view. You can assess with Doppler imaging or power Doppler imaging if you would like to check the vascularity. I mentioned about palpation and sonotenal. I'm sure there are people who would like to read further, and this is one of our cutting edge papers published in the Journal of Neurology recently, how you can correlate the histopathological findings at different grades or periods of neuropathies, entrapment of different types of neuropathies in correlation with ultrasound findings. So if you go and check this paper, you will see different data like pathological assessment of edema, fibrosis, of the epineurium, of the endoneurium, of the perineurium, of the epineurium, or interfascicular regions, you will see some different tissue reactions and how you can correlate these. This is just a schematic for better understanding, schematic drawing for these lesions, how they ensue in acute and chronic phases and in relation to the surrounding vascularity. But you can check all these things and you can also see the corresponding ultrasound images like this one. So this is a high resolution ultrasound assessment for different types of neuropathies. And if you're interested, you can check all these details. You see the fascicular edema, eccentric. You can even count these fascicles. You see, this is called the honeycomb pattern. And this is the spaghetti pattern in the long axis. And do believe me, I mean, you can all see these things with MRI. And these are examples of different stages of acute and chronic neuropathies, how morphologically the nerves is getting swollen, contains edema, and also what happens to the fascicles, how they become confluent, and how they become edematous. And these are relations with the vessels, surrounding vessels. And this is, again, high resolution Doppler assessment, power Doppler assessment of the epineurial vascularity. And of course, seeing these things, again, I mentioned this is suture, seeing these things or relating these abnormal vascularity with the clinical findings of the patient is again the duty of the master chef. So you have to listen to the patient, physically examine the patient, then sonographically examine the patient, and eventually finalize your decision how to proceed. Don't forget the clinician or the surgeon is the master chef. Now, the rest of my presentation will comprise examples of different diagnostic and interventional cases. I will start from the cranial region and I will end up with the caudal region with the feet. And I will try to show as many as possible clinical cases and evidence-based data. So starting with the more cranial region, I gave this example of how we treat sutures in chronic migraine cases. Now, the suture injections is really a very recent, perhaps a hot topic and a detailed and extreme technical injection because these patients are usually treated with a sort of preamp trial where botulinum toxin is suggested to be injected at 30 locations and whatsoever. But the sensory nerve endings exiting the skull from these sutures are usually or normally should be the target areas for giving the toxin and enriching with some intraneural pathways to the trigeminal ganglion and to treat the patient. So we've described this one and targeting the sutures or following the sutures and doing simultaneously injections with other techniques is quite impossible. So these are the sutures. These how they look on ultrasound. You see the step of phenomenon. This is one of the sutures. Any type of suture, of course, you can scan for. And this is an example of how we inject them. So this is the direct in-plane technique. Here's my needle. Here's the suture. And once we find the suture, you see how the botulinum toxin is distributed just around the suture. So perfect targeting, 100% precise guidance for touching the sutures. I mean, when I say touching in quotations, I mean, you're touching with the toxin, you're not touching with the needle, definitely. Uh, Cranial nerves, you can scan different cranial nerves. Of course, it should be clinically relevant. I mean, this is not just a fantasy. This is my optic nerve. So cranial, the second cranial nerve is being imaged here. So if you close the eyelids of the patient and put the probe on the patient, you can scan this nice optic nerve. This is the eyeball, and this is the optic nerve, and you see the rectus muscles. Why do we scan the optic nerve? Especially in cases where you would like to check for papilledema, especially in children. Checking for intracranial pressure increase is quite difficult with MRI because of different reasons, sedating the child and so forth. But very much easily, just holding the patient without any cardiac cocktail or whatsoever, you can scan the optic nerve and quite convenient and sometimes quite difficult with MRI. If you would like to target the trigeminal nerve, in different types of orofacial pain or the pterygoid muscles, it's again possible. Always we need to remember, I mean, can we access to that structure? I mean, to access or not definitely depends on the decision of the master chef. But then, can I access to this muscle is the answer to the question, can I see it? If you can see it, you can have access to it, no problem. Greater ocular nerve, again, if you would like to inject it for some painful cases, uh, definitely the cervical root. It's not just with, cervical disc herniation, but the different types of radicular flexopathies, you might want to target these structures. So if you put the probe just on the axial side, on the side of the neck, by the way, this is not the probe, this is an ultrasound. So ultrasound technology is something like this. So you just keep it in your pocket, and anywhere you would like to scan, you can use it. So if you use it just axial view, as also indicated in the insert, you can scan the axial view of the cervical root exiting the foramen. And here you can see the swollen cervical root. Okay. Again, it is you to correlate this swollen nerve root with the clinical scenario of the patient and then decide whether this nerve root should be the target for a possible intervention. And this is how it looks like on the long axis view. So this is the normal side and this is the swollen side, just exiting with the tubercle of the transverse process. Now, when we talk about surgical interventions, neurovascular interventions, I usually use this image because it's quite straightforward to ask the question, where do you think you're entering? I mean, this is the big chaos. How you dare to do a blind injection otherwise? Or how you do a fluoroscopy guided injection? Because if you don't use ultrasound guidance, the most common second alternative would be fluoroscopy. While in fluoroscopy, I usually use this slide. This is the only structure that you can scan for. This is the bones. So in fluoroscopy, you just see the bones. And then you try to predict, according to the appearance of the bony structures, you try to predict where the soft tissue would reside. Thinking that majority of the targets are confined to the soft tissue side, I mean, ultrasound guidance is even not comparable with MRI or with fluoroscopy guidance. So these are the nerve roots, for instance, here, scalene muscles, the sternocleidomastoid muscle, the stellate ganglion, usually targeted, and just next to which are the great vessels, the vein and the artery. So we also have some guides for the interventions of the cervical spine and the in the neck region. I don't go into details, not just for, I mentioned, mechanical problems, but sometimes could be related with neuralgia cases with different techniques. Again, I don't go into details. You can use the in-plane or out-plane techniques, but you have to be confident and comfortable during the procedure. It's not so uncommon to have a patient shouting, the physician sweating, and the big spinal needle on the screen lost on the ultrasound image. So it's not so uncommon. So you have to use the right technique. It's not just for the nerves, but also related muscles, where we do with dystonia cases. This is our guide again. We do study this with neurologists. They usually try to use the EMG guidance, so electrical stimulation, but with electrical stimulation, you can get the discharge, but you never be sure which muscle that would be giving the dystonic discharge unless you use ultrasound. Again, we use both, and we suggest that we combine both. So this is just an example of how we scan for the sternocleidomastoid muscle and also how we use the seeding technique to inject throughout the sternocleidomastoid muscle in a case of dystonia. So we just don't choose the most bulky area, but rather we try to, by the way, this is an innervation zone targeting procedure that I don't go into details of. You go to the end of the muscle, and once you're trying to withdraw the needle, you try to seed the toxin inside the muscle, and you will see how it's nicely distributed. So you're 100% sure where you're injecting. You're never perhaps injecting to the next muscle, and this is more effective if you just spread it in case of botulinum toxin injection, spread it throughout the innervation zone. This is the technique I mentioned. We say two-step guidance. I mean, use the EMG needle also to find the dystonic discharge. This is the EMG needle to locate the right muscle. So it's not just giving an injectate, but you can also do needle EMG using ultrasound guidance. For plexus diagnostic and interventional things, you can use ultrasound guidance, again, because the brachial plexus is not inside the bone. The subclavicular region could be difficult if you do not mobilize that region, but the subclavicular region, I said, the supraclavicular region is quite straightforward, and you can see all these pathologies. This is an example of a Behçet case where there was a big hemorrhage, and you can see the brachial plexus nerve compartments being separated with this huge hemorrhage, clotted hemorrhage. And you can nicely say that and easily say that, okay, the brachial plexopathy of the patient, the painful scenario, is definitely related with the local entrapment due to bleeding. This is an example of long thoracic nerve. This case was actually an orthopedic surgeon who was evaluated by EMG in your city, Izmir, by one of our expert electromyographers. And she told me, yeah, I suspect of a long thoracic nerve injury, but I cannot localize the exact crush region. Can you see it? Yeah, of course. Send the patient to us. So this is the normal axial view of the long thoracic nerve, and this is the long axis view, and this is how it looks like when it's swollen. The short axis and the long axis view of the long thoracic nerve. And again, with sonar palpation, with sonotinel, you cannot miss it. Another patient, well, there was already a polyneuropathy, but he had to stay in the ICU for a short period, after which, probably due to mechanical during transfers or other passive activities, probably due to mechanical reasons, there was a new onset accessory neuropathy, which could be nicely seen with ultrasound, the swollen accessory nerve. This is another thing that, again, we describe about selective peripheral neurolysis. So, in cases of spasticity, we just don't inject botulinum toxin to the muscles, to the innervation zones, but sometimes we target the nerves and we try to selectively target the motor branches of those peripheral nerves. In this case, was the musculocutaneous nerve. This is something contrary what pain physicians are doing. And once we shared this with them, they said, why do you block the motor nerves? We are very much afraid of blocking the motor nerves. Yeah, but that is for killing the pain. If you would like to treat the spasticity, definitely you need to block the motor branches. And ironically, if you block the sensory ends, it's also causing dysesthetic findings, which is quite difficult for the patient. So if you selectively would like to target the nerves, it's again possible with high resolution ultrasound. This is an example of a cubital tunnel syndrome patient. You can see that it's a very historic machine. Even I didn't have the Doppler function in this machine, but he was a waiter in our school, in our medical school, and he was describing a sort of intermittent cubital tunnel syndrome findings where the EMG was negative, was not contributory. And he was, upon further questioning, he was describing the complaints to and through when he carries for long periods the tray. And we said, okay, this causes isometric contraction of the muscles and also venous congestion. And once we did ultrasound evaluation, this is the ulnar nerve, and these two veins were interesting and next to each other. So if you apply pressure, the veins are, compressed. Arteries are never compressed, but the veins are usually compressed. So we said there are aberrant veins, and this explains the clinical scenario of the patient during venous congestion, causing intermittent cubital tunnel syndrome. So EMG is negative, and even if it was positive, it could never say that it could be related to the aberrant veins. So cubital tunnel syndrome. Another case of cubital tunnel syndrome due to HO, heterotopic ossification. Actually, in our cases in rehab medicine, we face with these complications, especially in traumatic brain injury or spinal cord injury patients. And HO, or let's say for the diagnosis, for the earliest diagnosis of HO, ultrasound is by far the most effective technique. Even during the periods where X-rays and CTs are negative, ultrasound shows a particular pattern on the ultrasound screen. So in this case, this is straightforward HO, but it was interesting that we could see the HO, but also how it was related with the nearby ulnar nerve. So it's not just the static positioning, but during dynamic movements, how the HO was impinging on the ulnar nerve could be demonstrated. This is another case of double crush ulnar nerve injury, where the expert electromyographer could locate one of the crush lesions to be related with at the level of the cubital tunnel, the bony tunnel, but he was asking me, I cannot find out the second crush area. So here is just within the FCU, the flexocarpial nervous muscle, the swollen ulnar nerve, and this is the normal side. And let's try to check the dynamic scanning for this. So this is the ulnar nerve, you see, proximal to the cubital tunnel, so you see the humerus in the short axis view. Now I'm going distal and just try to follow this nerve. So as soon as it's trying to enter the cubital tunnel, the bony tunnel, you see it's getting a little enlarged. And you can see from the electron side, there are some osteophytes that are possibly impinging on the nerve. So this is the site of the first crush. So if you follow it distally, the nerve is getting there. And then when you go more distal, the heads are fusing and causing just a single muscle. And here you see how the ulnar nerve is swollen with swollen individual fascicles. And this is where it exits the muscle. So it's all there. It's quite straightforward. And of course, at the same time, you do sonotinel and you ask the patient where he or she feels the sensory or dysesthetic findings. This is an example of dynamic scanning for the ulnar nerve, which is the snapping ulnar nerve. You see, the nerve is inside the tunnel, but with extension and flexion, oh, it's outside. Okay. And you see how swollen the nerve could be if it's under excessive friction. This was a case of neuropathic pain in the ulnar nerve area after angiography. You see the ecchymosis that was bleeding on the subcutaneous area, and we were suspecting perhaps the nerve is injured somewhere there. But once we scanned, we saw that the hematoma was just to the next to the ulnar nerve within the FCU muscle. So can you see at least 20 to 30 centimeters distance in between the clinical diagnosis and the sonographic diagnosis? So sometimes unexpectedly you can find extra things which is not consistent with the clinical examination findings. This was another interesting case where it was already operated. The ulnar nerve was already anteriorly transposed. So you see the muscle cushion. The nerve is inside the cushion and it's still swollen. But even with the small, gentle movements of the probe, passive movements of the probe, the nerve is once inside and once outside. So you tell back to the surgeon saying that, okay, the nerve is still protected, still inside the cushion, but is still under extra friction. And perhaps you can consider to revise your surgery. So unless you do this dynamic evaluation, no one could explain the claw fingers, claw hand of the patient, and the ulnar neuropathy disturbing the patient, especially at night. This is a typical example of Saturday night palsy. So this is at the level of the spiral groove. This is the radial nerve on the normal side, and this is the swollen nerve. So commonly in entrapment syndromes, just proximal to the site of entrapment, we see swollen nerves. It's swollen. Another entrapment of the radial nerve this time, this is again the humerus. This was a supracondylar fracture, which was fixated by the screw. And you see the very intimate relation of this radial nerve and the screw as it passes over this injured side, over this fracture side. So in this case, again, you discuss with the surgeon, okay, the fracture is already healed, but now the problem is related with the radial nerve. So do you plan to revise and take the screws out, or would you like to sacrifice this radial nerve or the pin, which is causing drop fingers or drop hand? Okay, so ultrasound can tell you everything, but you need to decide. This is an example of an injection of the ulnar nerve. Now, this is the swollen ulnar nerve. This is the bony tunnel, the cubital tunnel. Now, try to follow my needle from the right side. It will enter the right side just deep to the ulnar nerve. And once I start giving the fluid, it will be sort of hydrodissection, taking the nerve away from the epicondyle side. You see? Now I'm pushing further fluid. This anechoic zone pertains to the injectate. So pushing, pushing, and pushing the ulnar nerve. Okay? So this is an example of hydrodissection of the ulnar nerve apart from the surrounding bony structures. Okay? You don't need to do it always with corticosteroids or local anesthetics. You can use dextrose as well. This was a good example how we cooperated with one group of surgeons, but on the other hand, which we could not convince the other group of surgeons. This was a case again of fracture of the upper limb. During fixation, of course, unintentionally, the surgeon cut the posterior interosseous nerve. So you see the gap in between the two ends of the pin. And once I saw this, I said, okay, there is a gap in between, and there's no way that these nerve fibers will jump from the other side to the other side and get connected. And I mean, why would you not think about revision surgery? The initial surgeons who were following the patient because they were not aware of how ultrasound could scan all these injuries, they said, yeah, but perhaps there is edema, let's wait 2 or 3 weeks more. I said, yeah, but there is a gap. And then we sent the patient to another group, and who knows what we're doing with ultrasound. And this is how it looked like during surgery. So this is the radial nerve, this is the proximal side, and this is the pin, this one with the white asterisk, and this is the superficial radial nerve, the black asterisk. And this is the gap in between, okay? And this is the distal part. So the surgeon put a double layer sural nerve graft, and I mean, this is quite straightforward with ultrasound examination. And then the same surgeon started sending other pin patients to us. So this was another pin, which is swollen between the two heads of the supinator. And I said, this is the exact area of the entrapment. Shall I mark it on the screen? Yes. This is the mark, and this is how he operated, and he saw it during surgery. Now, I asked my colleague, yeah, but if I had not marked this, would you not have perhaps located the same lesion? He said no, because if I had not opened the sheath, the nerve from outside was not, so much apparent to be swollen. Once I cut the nerve sheath, I saw that it's really swollen inside it. So the concept of navigating the surgeon or the surgery is definitely crucial and should be kept in mind. And these are other pin cases. I don't go into details. Again, swollen pin in short and long axis, and this is during surgery. Another pin case where the lady was, having dropped fingers after a heavy period of knitting for 2 or 3 days, and this is how there was a sort of ganglion cyst just deep to it, and a little swollen, intact but swollen pin. This is the short axis view. This is the pin, and this is the superficial radial nerve. And this is after we drained the fluid, how relaxed and comfortable the pin became on the control visit, also on the short axis view. So perfect diagnosis, prompt interaction with the patient and physician, precise guidance, and close follow-up. It's all possible with ultrasound. This is another example of pin entrapment, this time in a patient with rheumatoid arthritis, again, this time due to a synovial cyst. So the pin is over there. Sometimes it's so difficult to drain these chronic, let's say, the content, which is chronically very thick and cannot be drained. In case you cannot do it, you can just inject it. This is an example of a pin injection. So if I can see it, I can have access to it. This is my swollen pin, and this is my direct in-plane technique, just getting next to it and injecting perineural. Now, I will show in the coming slides, not each and every injection could be perineural. Depending on what you see on the screen and how you suspect in clinically in your patient, you might change your procedure as well. Sometimes you do hyperdissection. Sometimes you do anti-inflammatory injection. Sometimes you prefer a regenerative injection, and sometimes perhaps you just skip the intervention and send the patient immediately to surgery. These are examples of Charcot-Marie-Tooth diseases of the ulnar nerve. This is the normal side, and this is the abnormal side. And here is at the spiral groove level, the swollen radial nerve and the normal radial nerve. Another example of radial nerve pathology, this time a mass. Sometimes you suspect about entrapment, but you might end up finding a mass lesion. This was the pediatrician himself, the patient, and he was explaining some radial nerve and pin complaints. So this was the swollen pin, what we found initially. And this is the normal side. Between the two heads of the supinator, short axis view, this is the normal pin, and this is the swollen pin. But as we moved the probe more proximal, at the spiral groove level, the radial nerve became even much more swollen. And this actually looked like something more than a swelling. So this is the normal radial side, no, radial nerve on the normal side, and this is the swollen side. And once we move the probe in the long axis, this is the typical and pathognomonic finding of schwannomas, which is the rat tail appearance. So this is the white line entering and exiting the mass. So this is how schwannomas typically look like in ultrasound examination. And the way we differentiate between schwannomas and neurofibromas also lies in the fact that they are much more vascular. So if you just apply power Doppler imaging, you can see the vascularity. Of course, in these cases, you have to be also cautious against the peripheral nerve sheath tumors, which might be sometimes not always benign. Some entrapments of the median nerve at the elbow, at the forearm. Well, in this case, it was due to arteriovenous graft. So it's not always typical entrapment in each and every case. It's sometimes quite extraordinary. At the scrotus ligament level, again, you can see the nice osteophyte here, and just to the vessel and the entrapped nerve. Especially in patients using anti-aggregant or anticoagulant treatment, sometimes the bleeding is not around the nerve and not compressing on the nerve as a sort of a mass lesion, but sometimes it's inside the nerve sheath. This is the example of the median nerve intraneural bleeding. Here you see the anechoic compartment just around the nerve, and here is in the long axis. And here you can see distally it's quite normal at the carpal tunnel level. We measured the CSA. Sometimes they do accumulate inside the nerve sheath. I will show a sciatic nerve entrapment case in the coming slides. Sometimes the patient is sent with a suspected diagnosis of entrapment, but you end up finding that, okay, in this case, the anterior interosseous syndrome was suspected, but once you physically examine the patient, you see that the flexion at the distal interphalangeal joint is lacking only on the thumb. So it's suspected perhaps, okay, the anterior interosseous looks quite normal. Perhaps it's related with the FPL, the flexor pollicis longus tendon. So here is the normal site, the FPL in the long axis, in the short axis, and here's the absent FPL, both on the long axis and the short axis. So ultrasound can show you sometimes something other than the routine expected entrapment. I said if you see things you can quantify or you can qualify. This was the finishing thesis, one of our theses from the department. So you can also compare it with the functionality of the patients. I don't go into details. I said about technology, and different machines have different technologies. It depends on what you have in your machine. If you have a lasso, and as the master chef, if you think that a lasso would add to your clinical or sonography findings in that particular case, you can also do elastography evaluations. As the name implies, I mean, it shows you some assessment features regarding the elasticity of the tissue. So either the nerve or the surrounding tissues, if you're interested in the elasticity of those tissues, and if you think that would add to your diagnosis, you can apply also elastography. This is one of our umbrella reviews, our elastography can be used in CTS. I mentioned typical entrapment is something like this. So this is the entrapment site. This is the entrapment site. So proximal to the entrapment site, you will see swelling of the nerve. Sometimes, especially in operated cases, you see also the subcutaneous edema. This is after operation. The distal part could also be swollen, but usually the entrapment site is getting decreased in size, and the proximal site immediately to the entrapment site is getting swollen. That is the typical ultrasonographic feature of an entrapment syndrome. So this is, again, the proximal entrapment site and the distal site where you see the median nerve as swollen in the short axis view. Again, typical swollen median nerves. Median nerves. Sometimes, again, it might tell you that, okay, the nerve is entrapped, but it's related with nearby soft tissues, in this case, due to tenosynovitis. So if you would like to target during an intervention, if you would like to target some tissues, perhaps the extensor tendons would be the nice or the prompt targets rather than the nerve itself. Okay, so in the past, we were usually saying that, okay, shall I inject this patient and shall I do a carpal tunnel syndrome injection? At the moment, with all these data, it does not make sense. You have to explain what type of carpal tunnel syndrome are we discussing about. Is it due to just the nerve entrapment? Is it due to the retinaculum itself? It's due to the nerve itself? It's around the soft tissues? And which structures you would like to target? What type of injector you would like to inject, and what path you are preferring to go inside your target? Now, this is again a nice recent example, a patient with median nerve entrapment. Now, this is the normal median nerve. Follow this. Once you do flexion and extension of the short axis, you nicely see how the median nerve is mobilized over the flexor tendons. Okay, this is the normal median nerve. If you go to the entrap site, you move the tendons, but the median nerve is stuck. And you nicely understand that the problem is between the retinaculum and the median nerve. So what you would like to target in that case would be to hydrodissect the median nerve from the retinaculum. But in another case of median nerve entrapment, something else would be your target. Median nerve entrapment, proximal and distal after fracture and surgery. Now, this is the swollen median nerve in the long axis. And once I do flexion and extension, you see how the underlying screw is causing impingement from below to the overlying median nerve and how swollen the nerve becomes. See? And on this side, this is the short axis view of another patient where you see the big metallic plate giving the huge artifact, and it's just more proximal. You see the median nerve is in the forearm getting more deep and just becoming very close to this metallic plate, and you see the movement of the arm, and this is how we manipulate the patient. And on compression, we're trying to confirm that that is the most painful area of the patient. And you see the FCR that is swollen, but that's not the site of compression. That's the metallic plate. And once you press, and the patient says, yes, that's the most painful area. And you see something like this on the screen. There is no better sensitive and specific imaging modality or examination tool at the moment with this current technology. Another example of an aberrant muscle, this time causing the carpal tunnel syndrome of this patient. You see the intraoperative synchronous movement of the intraoperative and the ultrasound dynamic assessment. Here is the muscle, the black, sorry. Okay, so here's the muscle, a bent muscle, and just next to it is the median nerve. And this is the muscle and the tendon. Once you move the fingers, you see how the muscle is impinging on the median nerve just next to it. Okay, so in this case, you never lose time with physical therapy or splinting or injection or whatsoever. You just send the patient to surgery. Of course, if it's clinically consistent with the findings of the patient, you send the patient immediately to surgery just to resect that muscle. Sometimes the entrapment is more severe, or in chronic cases, would be a sort of neuroma formation. In these cases, the zonal tunnel is really, really very much painful. And this is a typical example of how you can hydrodissect the median nerve. So this is my swollen median nerve, and here's the retinaculum. This is the carpal tunnel. You can see the flexor tendons, and here's my insulin injector. I do it with a very small injector because that's so superficial. I'm 100% sure I'm just deep to the flexor retinaculum and giving the fluid and pushing the median nerve away and getting it released from the entrapped site due to the retinaculum. Again, data how you can change the treatment outcome if you do ultrasound guided injections. In this case, with PRP, carpal tunnel, that was another finishing thesis of ours. Sometimes you can even do a comparison between perineural injection and a peritendinous injection. So does it make difference in idiopathic carpal tunnel syndrome? I don't go into details, but you can do all these evaluations with direct guidance, direct measurements using ultrasound technology. So hydrodissection, I just mentioned, it's quite relevant and it's quite recent and hot topic. Mechanically, you just separate the entrapped structure with the surrounding soft tissues. But again, our meta-analysis, especially for the carpal tunnel syndrome, have shown that it's quite effective. Dextrose hydrodissection is quite effective. Actually, that is the best. It seems to be the best, followed by PRP in terms of symptom relief. But with respect to functional improvement, splinting is ranking higher than these two injections. And in both assessments, either the symptom relief or the functionality, corticosteroid and saline injections are ranking the fourth or the fifth. So there are now new data and robust data, and we can only discuss these with the presence of ultrasound. I mentioned sometimes we see further than a surgeon, so a healthy median nerve is never cut and looked inside, whether it contains an aberrant structure. But here you see the bifid median nerve, sometimes apparent from outside, and this is a trifascicular median nerve, sometimes causing entrapment. Sometimes a persistent median artery is also accompanying. You see, so bifid median nerve and also a persistent median artery. This is actually the secretary of our orthopedic surgery department, who had been operated twice. And you still see the median nerve swollen. Carpal tunnel syndrome was the reason for the surgery. Still swollen, entrapment is still there. And there is also a persistent median artery, but never checked before surgery. And after the second surgery, now the patient also has some Guyon tunnel problem. So this is the Guyon's, the ulnar nerve entrapped or swollen at the Guyon's canal. This was a more interesting patient where there was a persistent median artery, but it was also a thrombotic occlusion inside the persistent median artery. So in this case, you're discussing about a carpal tunnel syndrome-like scenario, where the problem is due to the persistent median artery and its thrombotic occlusion. So you don't treat with physical therapy. You don't treat with injection. You don't send the patient to carpal tunnel surgery. You just give anticoagulant or antiaggregant treatment. Again, ultrasound shifts you this therapeutic option to this end of the clinical spectrum. You would never treat a patient suspicious with carpal tunnel syndrome with anticoagulant treatment unless you put the probe on your patient. Another interesting case of median nerve, this one is asymptomatic. This was, again, one of our colleagues. You see a very high resolution ultrasound assessment. It was during one of our neuromuscular courses. So you see the bifid median nerve. This is all the median nerve. You see two persistent median veins and one persistent median artery. Now, just upon palpation or compression, you see that the veins disappear, but the artery is there. And also with Doppler imaging, you see the different flow patterns. So this is an arterial flow pattern, and this is a venous flow pattern. And then we told our colleague, hey, okay, you are asymptomatic now, but you might perhaps suffer from carpal tunnel symptoms. So let's apply a tourniquet, and you just open and close your fist just stimulating a venous congestion scenario. So now you see the artery is normally larger than the vein, but in this case, with the tourniquet application and with that movement, the vein is getting larger and larger. So we said, in the future, if you have carpal tunnel findings, be aware of this aberrant vascularity in your just next to your median nerve, and especially with venous congestion. Once you have symptoms, be sure that it's related with these persistent median veins and arteries. Neurofibromas, by the way, it's already 1 hour. I mean, when you are bored, you can stop me because otherwise I might not stop if I start talking about ultrasound. Just anytime you can stop me or ask questions or uh, any comments are welcome. Otherwise, I go on. Neurofibromas, again.
It's okay.
Okay,
We are
okay,
thrilled
thank
and
you.
listening.
Okay, stop me whenever you want, okay? So neurofibromas, I'll give the examples of neurofibromas. It's quite similar to schwannomas, but in this case, we don't have the rat tail. This is the axial view. Again, with some skin problems also, it could be affecting some peripheral nerves, but you can even not name them. It's so superficial and so small. You can see them in short axis views, some swellings, subcutaneous neurofibromas, and this is like the beads on a string. So the peripheral nerve can be swollen as much as this one, and as nicely swollen as that one. This is an example of fibrolipomatous hamartoma or neurofibrolipoma. Now, this paper has two cases. One was operated. You can see that the retinaculum here is swollen. So this is the area where the surgeons cut. You see the track to the skin. So this is the retinaculum that's swollen, that has been operated. Actually, this case was operated with a suspicion of carpal tunnel syndrome, and the surgeon operated and saw that it was swollen, and he said, okay, this is schwannoma, let me close it back. Now, if ultrasound had been performed in advance, it could have been quite straightforward or nicely understood that this is neurofibrolipoma, or with the other name of fibrolipomatous hamartoma. So nothing to be operated unless you would like to resect it out. You can see the nice typical pattern and the spaghetti view on the long axis. This is the patient we could protect from surgery. We said this is a neurofibrolipoma. So if you would like to perform a surgery, do it for this one, not for the carpal tunnel syndrome, and it's not operated. So two examples of neurofibrolipomas. Another example of how a surgeon is asking for a nice navigation before the surgery. He said, okay, there is a ganglion cyst. I know it. I will excise it, but I want to know its precise relation with just the underlying distal branch of the median nerve. So we just tried to describe how thick it was, how deep it was, and how close it was to the nerve itself. And this is how it looked like when the surgeon opened. No surprise during surgery. Lepra, okay, we don't have lepra that much anymore, but not just with the swollen nerves, especially with the epineurium, but you can also scan for different skin pathologies at the same time with lepra cases. Uh, Sorry, this was example of swollen median and ulnar nerves with nail and hyperkeratotic skin findings of the finger. So this is how a nail looks like in water. Sometimes we use water and we insert the fingers inside it and we just scan it inside the water. Again, schwannomas, I just skip it. Now I'm going to the lower limb, and this is how we commonly scan for neuralgia cases. So this is the swollen lateral femoral cutaneous nerve just next to the anterior superior iliac spine and just deep to the inguinal ligament. Sometimes it's deep to the ligament, sometimes it's above it, sometimes it's through it, and this is the normal side. You always compare it, okay? So, I mean, in the past, I was thinking that it was really a small nerve, but once we also did cadaveric dissections, we saw that it's not a small nerve, and it's nicely seen in ultrasound. So this is another example of the normal site and the swollen side. You can see nicely the small and enlarged fascicles, even inside the lateral femoral cutaneous nerve. Again, we have different approach when compared with that of pain physicians. They have fixed protocols just targeting at one part of the lateral female cutaneous nerve, but we usually do, we scan for it, we find where it's swollen, where exactly it's swollen, and what exactly is causing the entrapment. And we change our treatment protocol or interventional protocol accordingly. This is how a routine neuralgia injection can be done. This is the needle, so direct implant technique. This is the swollen uh, lateral femoral cutaneous nerve, and this is a perineural injection. But in some other cases, where there is the bony spur on the spine, perhaps you might want to hydrodissect the nerve from the inguinal ligament or from the spine side. The cluneal nerves, sometimes they are also really causing problems in the differential diagnosis of low back pain. So you can also scan for the cluneal nerves at the fatty tunnel. There it is, and this is the MRI. You see how high resolution ultrasound can show better than this MRI. Different cluneal nerves can be targeted. I don't go into details. I think I need to skip this video of the middle cluneal nerve. Okay.
Is it?
I think because of the video, it's stuck.
You can try to shut down the slideshow mode and again.
Let me do it.
Yeah, yeah.
Okay. Oh, it doesn't let me share my screen again.
No.
Mhm.
You can share, Professor.
Let me try again, but it doesn't. Just a second. I think there is a devil's eye. I don't know whose eye is this, but okay, just a second.
It's okay. Take your time.
You see it now?
Yes, we can.
Okay, great. So this is an example of, I just skipped the cluneal nerve. It was a huge video, so perhaps it was stuck. So this is an example of a sciatic nerve injury after a knife injury. It was cut by a knife. So this is the normal side. You see is the axial view of the sciatic nerve on the normal side. And this is how it looks like when it's intact, but it's really abnormal, swollen, heterogeneous. And this is the long axis view with a split screen. This is the whole sciatic nerve. So this is quite the normal side on the proximal and distal regions, and this is where the site of injury. So morphologically, you can follow this nerve, but again, it does not give idea about the electrophysiological status of the same nerve. So use EMG and ultrasound complementary. This is a very recent and another interesting case of ours where this patient was like a very young girl with chronic nephrotic syndrome, had to use steroids for a long period with high doses, and both hips were replaced due to avascular necrosis of the femoral heads. Now, the left side surgery was uneventful, but 6 months later, she was operated for the right side as well. But the surgeon during the operation considered that the bone quality is not perfect. So let me put these two wires, the circulate wires. The next day after surgery, the patient had total foot drop. And although the EMG was also, sorry, although the EMG was also confirming the total axonal loss of the sciatic nerve, she was somehow followed. And 6 months later, another orthopedic surgeon saw the patient and said, perhaps there could be an unintentional impingement with the wires and squeezing the sciatic nerve within the wire. So he just phoned me, could you see if there is an entrapment of the sciatic nerve? I said, of course, send the patient to us. And this is, the patient is lying prone on the examination bed, and this is the position of my probe. Now let's see the sciatic nerve in short axis. This is the sciatic nerve. Once I follow the probe going proximal to the buttock, the nerve is diving inside and just try to watch out here. There is a foreign object there. And thereafter, I lose it. This is the callus tissue. Now, this is the long axis view. So the sciatic nerve is here. You see the asterisk. And then when I go proximal, it dives deep. And again, you can see a sort of metallic structure over there. So I said probably it's stuck within the wire. And this is after surgery. You see, the wire is here. This is the wire. And this is how the sciatic nerve is completely encircled and squeezed and entrapped within the wire. Well, unfortunately, the patient was planned to undergo a tendon transfer surgery, but we said, let's excise and remove this wire first, and let's see what happens. If the sciatic nerve is improving, okay, I mean, forget about the tendon transfers. Then the same surgeon group sent us this sciatic nerve case to us. This patient was using, again, anti-aggregant treatment. After heavy jogging period during summer, she started to have drop foot. So again, like the median nerve patient, you see the bleeding inside the sciatic nerve sheath. And you see the bleeding over there in the short axis view. And we told the surgeon just cut here. And this is how it looked like during surgery. They reported that there was a sort of fibrous extra tissue within the sheath, which was quite reminiscent of a former hemorrhage. This is an example of how we can shoot the sciatic nerve, actually shoot next to the sciatic nerve. I just avoided the sciatic nerve on the middle side of the screen. This is an example of how we inject the piriformis muscle. So this is the gluteus maximus. This is the subcutaneous fat. The middle is somewhere there, okay? Sometimes it's quite difficult if the poke and the angulation of the middle is quite steep. So once I start giving the botulinum toxin within the piriformis muscle, you will see it. Sometimes we go with steroids, sometimes we go with local anesthetics, but in this case, and sometimes also trying to understand which muscle to resect, you block the muscle, in this case with botulinum toxin. We also do this for thoracic outlet syndrome patients, perhaps, to more confirm that that particular muscle is causing the entrapment on the neurovascular bundle. So this is how we can inject the piriformis muscle. Sometimes it's not the sciatic nerve problem. This was the patient with atrophy on the buttocks, and the patient was sent with a suspected diagnosis of muscle atrophy and nerve entrapment. But this is the normal side, so this is the fat. This is the muscle, and here you see the lack of fat layer, but the muscle is quite normal. This is a very healthy starry sky appearance of an axial view of a muscle. So we reported that it was really related with the fat atrophy rather than the muscle atrophy. So the diagnosis immediately shifts from a muscle dystrophy to a lipodystrophy. Okay. Again, quantification of sciatic nerves. This was a study we did to assess unilateral sciatica, where we had the hypothesis, okay, in chronic periods, you give these patients anti-epileptic neuropathic pain treatment, but the sciatic nerves distally are still edematous. So why not still go on with the anti-inflammatory treatment? So this was a study we did to compare the CSA measurements of the sciatic nerves. I don't go into details, but you can quantify. Whatever you see, you can quantify. Again, different types of HO or post-operative cases with spinal cord injury patients. This is a peroneal neuropathy. The intact peroneal nerve, this is at the fibular head level, just turning around the fibular head. So one crush is at the exact site is the peroneal, the fibular head, and also proximally. The nerve is intact, still not functioning well, but still heterogeneous and not perfectly healed morphologically either. With amputations, you can scan for nerve problems, also for neuromas. So this is the normal sciatic nerve in short axis and long axis, and this is how it looks like after amputation. On the peroneal side, it's abnormal, but the neuroma formation is more on the tibial side. Again, a historic paper of ours, an historic image of ours with our old machines. I was in the military service, and I saw this transtibial amputee patient with an osteophyte over there. And I said, I'm not that much expert in those years in neuromas. I said, but this looks like a neuroma. That was also another orthopedic surgeon, also in military service, saying that I looked at the CT, and also the CT report said no neuroma. Okay, let's check once again, come together, and we do it once again. And I said, this is the place I suspect of a neuroma, just next to this osteophyte. There it is. And this was 2 days later. He brought back to us the photograph of the neuroma. And in certain cases, it's not just a morphological assessment of a particular nerve, but it's also understanding or better assessing the extent of involvement, especially in polyneuropathies. Could be some genetic problems, could be some rheumatic problems. You cannot scan all limb and check all nerves in one limb or the whole body for different nerves. But with the ultrasound probe, you can put it in the vagus, you can put it in the brachial plexus, you can put it anywhere on the arm, anywhere on the limb, anywhere on the trunk. So it's quite convenient. So for understanding the extent of involvement in chronic or different polyneuropathies, it's quite contributory. And in this case, this is PAN, polyarteritis nodosa, and Wegener's cases. Again, neurofibromatosis cases. This is from our old machine again. This was one of the first neurofibromas we saw. This is from the vagus, and you can see all these typical swelling sites. Type 2 as well, of course, not the central ones, but the peripheral involvement can be scanned. This is the neurofibroma, or just an isolated neurofibroma in the sciatic nerve. This is the long axis view of the sciatic nerve. Peroneal nerve after casting, so that was a bony fracture, and the patient was capped in a cast, and this is the normal side just before the bifurcation of the deep and the superficial peroneal nerve, and this is the swollen, intact but swollen. So it's not due to the callus tissue, but it was more related with the cast of the patient. So after the casting, entrapment clearly improved. Another peroneal entrapment was suspected at the fibular head level, was an adolescent, and this is the normal peroneal nerve. This is the swollen nerve, but just next to which you can see the enchondroma. So the diagnosis is yes, entrapment, but the underlying cause is enchondroma. So you can discuss whether it needs to be resected or what type of protocols or approaches you would like to apply for this patient. Peroneal nerve, intact, swollen. You see the abnormal fascicles and how you can reach that peroneal nerve. This is an injection of a regenerative injection of peroneal neuropathy. So here's my needle. And in this case, I'm just going deep to the peroneal nerve. And then once I start giving the injectate, you can nicely see that how it's distributed. You're 100% sure that your fluid is touching the nerve, but you're not injuring any other thing, either on the nerve side or on the path you're causing. Again, anything you see can be blocked. Genicular nerves can also be blocked in case of painful scenarios. Superficial peroneal nerve was a remnant after a tumoral resection. You see how swollen when compared with the normal side. So you can say, okay, this is the swollen superficial nerve, and this is the tract, and that's probably related with the resection and unintentional injury of the nerve. Tarsal tunnel, the medial and lateral plantar nerves here. This is the vascular bundle just next to it. And you see how you go distal and they separate, and the inferior calcaneal next to them. And this is the long axis view of the inferior calcaneal nerve. Again, anything, as long as your technology allows for anything that is outside the bones can be seen. Some cysts could be causing tarsal tunnel syndrome in this case. Sometimes distal or proximal to the tarsal tunnel, it's not always at the level of the tarsal tunnel, or sometimes deep soft tissue injections in diabetic legs can be causing. And just finalizing with the motor neuroma, you see how dynamically we scan for, you see this jumping neuroma. As soon as you squeeze with the Miller's test, inside giving the artifact, outside a nice anechoic jumping structure. So once you find this, of course, you selectively inject that intermetatarsal space, not like the blind injectors in multiple areas, just like standing love space. So this is an in-plane direct injection. So here's the needle, and here's the target intermetatarsal space. This is how we commonly inject it using the in-plane direct approach. In-plane means that you see the whole needle during the procedure. You see the injection, how it's distributed. You can also do this because it's a rough injection. You can do it outplane, which means the probe is like this and the needle is like this. And then you can just see the tip of the needle. And then once you give the fluid, you can again nicely see the distribution of the fluid, and you're 100% sure you are giving the injectate between the two metatarsal heads, and you're filling all space where the neuroma resides. You can assess the nerves, but also the muscles that are innervated by those nerves. This is a patient, this is the tibialis anterior on the healthy side. This is a patient with L4-5 disc problem with chronic denervation of the tibialis anterior, how a muscle looks like once it's denervated. And this is how a perfect muscle looks like. This is an example of the gastric medial head. And the reason I put this, how you can nicely scan dynamically these structures, also the neurovascular bundle within the structure inside the muscle. So this is a perfectly contractile medial head of the gastric is. We do assess these angles and these pernation structures once we would like to quantify them. I'm finishing with a few slides. So technology, again, coming back to MRI versus ultrasound, technology is the thing that you need to keep in mind. In ultrasound, you also have different technologies, the 3D web format images. So this is my forearm. I have 3D imaging of my median nerve. I cut it. I do reformat imaging. So this is my median nerve with the reformat and slides section. It's related with all technology. And this is what we are doing. This is a recent video from our paper in a patient with dactylitis. So you can have 3D vascular involvement. And on the right side, you see how we apply artificial intelligence while we simultaneously scan. This is on the right side is our new application that will be in the market soon. Again, like elsewhere, artificial intelligence is also used for assessing the nerves, getting their simultaneous CSA measurements or other thickness measurements. If you would like to read further, I would suggest that you go to this upper limb peripheral nerve paper or lower limb peripheral nerve paper, cervical region nerve paper, or trunk nerves, or cutaneous nerves. You can scan for any cutaneous nerve you would like to check for, of course, if it makes sense, and the spine. So this is our spine protocol. But again, anything inside the bone cannot be scanned. Only one exception is the babies, the infants or neonates. In a newborn baby, because the spinous processes on the superficial zones have not yet ossified, you can see the spinal cord. So this is the conus, this is the cauda, and these are the anterior corpus of the vertebral bodies. So including the spine can be scanned, but in adults, we just see as long as the bones permit us to see for different spinal injections. Technology is improving. I've shown this is the ultrasound, but different probes and different techniques are evolving. And you see on the right side some glasses you wear, and like the glasses or the microscopic instruments you use in surgery, you use these things, and those glasses compose a virtual screen, and you never look at the screen of ultrasound, but you just try to intervene on your patient, and that's providing a virtual screen on your patient's limb or nerve or whatsoever. So probably in the past, in the future, there will be some sort of ring-like structures that you will wear on the tip of your finger, touch the patient, there will be a virtual screen and you will see anything, perhaps also in addition to ultrasound. So with these technologies, this is one of our recent concepts. We also would like to enter the match, especially for different regions. I mean, bench-side ultrasonography is there, but entering the match, we just wrote this saying that, okay, you stop the match and look at if the player is injured, instead of looking at the score or the net touch or the line touch, just you can even enter the match with using this technology. I'm finishing with this slide. So this is tongue ultrasound. If you put the probe just deep to your chin, you can scan the tongue for sarcopenia, for dysphagia, or for some swallowing problems. And the reason I put this, life after ultrasound and before ultrasound is different. And if you're not doing ultrasound, we're not speaking the same language. And I hope I could raise some awareness as regards the use of ultrasound in clinical practice, in particular for peripheral nerve problems. Thank you for your attention.
Thank you so much, Professor. I'd like to express my gratitude. To be honest, in the beginning, I was quite skeptical because, as you mentioned, because of the sophisticated MRI and NCT, I was wondering what else can the ultrasounds offer. But right now, thanks to you, I see that there are so many things. And I hope that audience also saw the ultrasound with different perspective. Thank you for that. And I could feel the passion with every slide you were showing, and like we couldn't like within a blink of an eye, like 90 minutes passed. So we were really thrilled to have you, and thank you so much.
Thank you, my pleasure.
Since I don't see questions in the chat, I have a couple of questions with your permission. You mentioned the ultrasound guided hydro dissection, which is a hot topic for today. So I was wondering, how often do you use as a Doppler assistance? When do you use it along with ultrasound, and how can it assist you, like?
Yeah, the use of Doppler imaging, mainly power Doppler imaging, is usually suggested to, let's say, help the sonographer or the person who's doing the intervention to avoid the vessels, okay? Or in certain very small nerve structures to locate the nerves because they are usually accompanied by vessels, okay? So for instance, when you're doing a suprascapular block, if you're unable to localize the exact place of the nerve, you might use the Doppler and see the accompanying artery. This is also very much similar to the pudendal nerve injection that we do. You just see the internal pudendal artery, and you just imagine that next to it, on either side, should reside the accompanying nerve. So if you would like to just give the solution around that zone, that would be 100% correct injection. So either to locate the vessels, to find indirectly the accompanying nerves, or to locate the vessels and to avoid them, the Doppler imaging is used, not necessarily or not only for the hydrodissection, but for any type of intervention. Of course, when we're talking about nerves, that is, a delicate intervention. We're not talking about a gross muscle injection, but especially for delicate structures and where the location or the zone is quite chaotic and crowded with different other things that you would definitely would like to avoid, it's suggested you use power Doppler imaging. Okay.
Thank you so much. And one more question about dextrose and botulinum toxin. I was wondering for how long the effect lasts, like clinical relief for the patients, and how often do you have to repeat the procedure, and what is the interval between procedures?
Okay, I mean, this is very much important, a very valuable question, because it again gives importance to the clinical assessment or the clinical decision making of the master chef. Okay, now not each and every carpal tunnel syndrome patient, or not each and every, let's say, painful scenario where you would like to block the nerve is not the same. Sometimes you scan. I've given several examples from the carpal tunnel. I will just give another example. Sometimes you scan, you see a swollen nerve, and you, let's say, see that it's related with a mechanical entrapment, okay? you might choose to hydrodissect the retinaculum, for instance, or the surrounding tendons. But at the same time, you might also prefer to inject with a sort of anti-inflammatory mixture. In this case, for instance, corticosteroids. Okay. Now, depending on the injectate, or sometimes a combination of the injectate, the duration of action is different. Okay. So with corticosteroids is different, with dextrose is different, with PRP is different, and not with carpal tunnel, but botulinum toxin is different. Okay. So depending on your approach, your way of treatment, is it anti-inflammatory? Is it nerve blockage? It's just pain killing? It's just regenerative, or it's just killing the muscle? Depending on the approach and depending on the injectate, the duration of action is different, and of course the repeat intervention is also different. Okay, with dextrose, it's just dextrose. You can do it every week, for instance. And uh, again, once you relieve the entrapment, and let's say on the control visit, if you think it suffice, okay, you stay there. But if you think that it does not suffice, you can go with repeat injections. But you are not that much uh, comfortable if you are doing repeat corticosteroid injections. Okay. So, and I also know that surgeons sometimes do not like their patients to be injected with corticosteroids too often, because once they open, they find so much fibrotic complications and so on and so on. So, especially with steroids, you have to be more cautious. But with dextrose, with PRP, I mean, you are more comfortable, and you have it's how can I say? I mean, it's more flexible. Okay, the approach is more flexible.
Yeah, that makes sense. Thank you. Thank you for your response. Now I see the chat is full with gratitude and the words of thanks. Let me read one by one. So Vasib Iqbal is writing, thank you, Professor Levent. Seham is
Wasim is
writing.
from Pakistan. He wrote to
Okay.
me. I will.
Okay. Seham is I don't know. He hasn't written where he is. I'm assuming from Turkey. In
No, Wasim is from
US.
Pakistan.
No.
He's an expert in EMG, and he's asking a biased question: how ultrasound is better than EMG guided botox?
Okay.
Can I reply? I can see the question. Is it the same question you're talking about, Madonna?
No, like
How
in
ultrasound?
genicular and in block, what type of injectates and pain relief lasts for how long? Yeah. I think you partially already
Okay,
replied.
the last question Wasim is asking is how ultrasound is better than EMG guiding botox. Now, EMG or electrical stimulation can find let's say, the discharge, the pathological discharge of the muscle. But once you insert the needle, and once you push the toxin, you can never be certain in which compartment you're giving the injectate. Okay? So, targeting morphological a morphological thing is possible with ultrasound. EMG can be used to target something functionally. I've given the dystonia example, but you can never be sure. Okay, this is the dystonic muscle, but which muscle that is, you can never be sure. Or once you start pushing the toxin, you can never be sure in an atrophic muscle that the toxin is not distributed to the next compartment. Okay, so I mean they are not in the same segment. I mean it's not comparable for EMG versus ultrasound guided, and the mentality is not the same thing. Okay. Is there another question about from Wasim? No. So you were
No.
asking something
Yeah.
about genicular.
I
No,
was
so
reading about Seham after like the you
Okay.
see in genicular and block, what type of injectates and pain relief last for how long?
Well, I mean, I didn't go into details about the technical things, but depending on what you inject, it's different, and it's not, as I mentioned, different protocols, different approaches exist, and not each and every center has a fixed protocol. I've given all the details regarding the carpal tunnel syndrome injection. where dextrose versus steroids versus splinting versus PRP injections, okay? But for genicular blocks, I mean, I don't have a robust data in mind, like with a meta-analysis, where it says this one is more effective or this one is more effective. But genicular block, as the name implies, I mean, by definition, is killing the nerves with local anesthetics. But if you use different types of local anesthetics, of course, the effect will be different. Okay.
Mm-hmm. I see from Rudy T. Excellent presentation. Thank you, Dr. Levent.
Madonna, Rudy is from Indonesia.
Oh.
He wrote to me.
All over the world.
Indonesia.
Okay, thank you. And Gunawan Kurnaydı. Thank you from Profesor Özçakar. And I have a question, what I see here from Seham. What is the role of ultrasound in diagnosis of thoracic outlet syndrome?
Yeah, I mean, yeah, thoracic outlet syndrome is again really a complicated scenario. Unless the clinician or the surgeon is familiar with what is actually going on inside the patient, it can really have a broad spectrum of findings related with the brachial plexus, related with the subclavian vein and artery, but more interestingly related with the stellate ganglion. So there are sometimes sympathetic or parasympathetic findings in the patient, like tachycardia, which by an unfamiliar physician would never be related in mind with the case of thoracic outlet syndrome. So I think he's trying to ask the sort of application of ultrasound in a local area to understand the entrapment of the nerves or the vessels, and with any nearby soft tissues. Yes, it's possible. So you can scan the brachial plexus or the distal part of the plexus from the nerve side. But if you're using Doppler, I mean, personally, I'm not using the detailed Doppler imaging as the radiologists are doing. So I refer my patients to radiology, but just with an overall evaluation. If you would like to see whether the great vessels are being impinged again by soft tissues, you can check for it. Or you can do some dynamic testing. And as I mentioned, for instance, if you suspect about the pectoralis minor, you might also plan to block the pectoralis minor either with local anesthetic or with botulinum toxin to guide the further treatment, including surgery. Okay, so you can see the soft tissues from the nerve side, from the vascular side, but if you are interested, also you can do some quantifications regarding how the blood flow is changed during different maneuvers, like the Addison test, the Roos test, or the costoclavicular test, or etc. Okay.
Mm-hmm. Thank you. And Lisa Nurhasana asks, thank you, Professor Özçakar. Can you explain again hydrodissection nerve in spasticity, like you mentioned before? I think the brachial spasticity, you just, rigidity, I think you mentioned.
Yeah. Okay, can you hear me, Madonna?
The Lisa...
Can you hear me, Madonna?
Yes, we can hear you.
Okay, I think there is the waxing remaining internet connection. So okay, I think there is a misunderstanding. I did not mention about hydrodissection in spasticity. I mentioned about selective nerve block. Mm-hmm. Perhaps Lisa is trying to mention about that paper. In selective nerve block is a sort of approach where you just target the motor nerves with phenol or alcohol. You block them and you avoid blocking the sensory parts of the nerves. Because when you do just a routine nerve blockage using phenol or alcohol, the most discomforting feature is dysesthesia. Then the patients do not like this. Okay. For that reason, I've given the example of the muscular cutaneous nerve. And what I said, you can selectively find the motor branches within the muscle, and you can kill those motor branches, avoiding the sensory parts. But I did not mention about sort of hydrodissection for spasticity.
I skipped one. Thanks from Eli Trituravati. Thank you for awesome presentation. And last question from Siham. What is the possible complication of phenol or alcohol?
I mean, again, sensory dysesthesias. If you just give it to the nerve itself, unless you do it selectively, okay?
Mm-hmm.
I mean, you can accept it as a complication, but it's more discomforting aspect to the patient, okay? It's not a sort of complication. It's what the patients do not like and what makes it more difficult to intervene for that patient, okay? I think Wasim is asking another question. Can we identify various types of myopathy? Yeah, in recent literature about the neuromuscular use of ultrasound, there was very nice review papers. I do not specifically remember the particular the references, but there are really nice reviews how you can use ultrasound morphologically, see the muscles, and try to understand what type of subgroup myopathy or muscular dystrophy that typical pattern pertains to. Okay, but in my clinical practice, I know those papers, but in my clinical practice, I don't have enough expertise to answer further what type of pathognomonic finding that ultrasonographic screenshot would belong to. I cannot say it in mind, but there are nice review papers. And the advantage of those neuromuscular ultrasonography is, like, for instance, if you would like to distinguish certain myopathies, you need to go with needle EMG. And doing needle EMG for each and every muscle in the body is quite painful for a patient. But putting the probe in each and every muscle you're interested is quite easy and straightforward. So, and they mention about even with static imaging, you can see the fasciculations within the muscle fibers, not the fibrillations, but the fasciculations. So that would be also helpful guiding you among the subgroups of muscular problems. Very nice papers, but I don't have personal experience in distinguishing those dystrophies.
And Nurullah Kuzmane, doctor, resident of neurosurgical program from Izmir, is writing, "Thank you, Professor. It was a great lecture." And Siham is asking, "Could you please give us a hint on concentration of phenol and alcohol preparations in nerve block? Many thanks."
No, simply no, because we do it with a big team in our department. I mean, I'm not the primary person dealing with spasticity. I'm the primary person from the ultrasound side, helping my colleagues preparing all these things. But I cannot give you the numbers and the ratios and so forth. I mean, I'm not the right person for that.
Thank you for honesty. Vasib is writing, "Thank you, Levent. Great as always." And he's giving the numbers here.
Yeah, perhaps those are the numbers for Seham's question.
Yes,
If it
I
is,
guess.
yeah, if it is, okay. Sorry, Seham.
Is it 5.4 or 2.5?
2.5% and 7.5%, if I'm not wrong. Yeah.
Okay.
Yeah. Okay. I don't see any more questions. Siham says, "Thank you, great lecture." Ahmad Abdul Salem texts, "Thank you for the great lecture."
From Kuwait.
And yeah. And from the audience, we have a lot of neurosurgeons in the audience. Maybe someone would like to ask a question. Dr. Shabi, maybe.
Thank you, Madonna. Thank you, Professor Özçakar. I followed your lecture with great interest. Thank you very much. I congratulate you. And I think my colleagues, young colleagues working at Hacettepe University after us are very lucky working with you, I think. I'm just wondering, do you have any specific signs for reflex sympathetic dystrophia after carpal tunnel surgery? A rare complication we see, but a severe complication. Thank you.
Yeah, I mean, I think that will be categorized for type 2 sort of complex regional pain syndrome, but the literature does not talk about specific or pathognomonic findings. I mean, you might perhaps try to scan the nerves if they undergo atrophy. I don't have personal experience, but since it's more related to the sympathetic nervous system, I have no experience in selectively imaging the sympathetic nervous system. I mean, we just do selective motor imaging and sensory and cutaneous nerves, but that could be an interesting topic, but I have no personal experience, and neither do I have any data that I can convey from the literature.
Thank you.
Thank you. And Seçilay Güneş says, thank you very much for this very nice presentation. Kamil Hoca, do you have any questions?
No, actually, and I want to thank to Professor Özçakar for this excellent presentation, and I want to thank everyone who joined us.